Good evening, everyone. On behalf of Gelflex and Bausch Lomb, a warm welcome to you all, and thanks for your interest in fitting Zenlens. So tonight, I'd take great pleasure in introducing Dr. Nicholas Gidosh, who is our expert presenter tonight. Dr. Gidosh is a private practice optometrist who specialises in specialty lens fitting. He's an honours graduate from the Michigan College of Optometry, completing an extra year as a cornea and contact lens resident in Michigan. Dr. Gidosh is a fellow of the American Academy of Optometry and has published several case studies and articles on scleral lenses and orthokeratology, as well as having spoken on these topics. He's a well-respected contact lens specialist, is an accomplished Zenlens fitter, and has conducted several workshops as a consultant to Bausch Lomb. And on that note, I'll hand the evening over to Dr. Gidosh. Thank you very much. I hope you'll enjoy it.
Thank you. Thank you for the introduction, and thank you for having me to be with you all today. And I'm really excited to be speaking about this topic because scleral lenses are a big part of my practice, and it's maybe the thing I enjoy most about optometry. So hopefully we'll give you some information to improve some confidence out there that you're willing to give these lenses some more tries, and hopefully you end up enjoying it just as much as I do. So there's my disclosure about Bausch Lomb. And the company, the specialty vision products side of the company, is got several missions involving, educating practitioners and fitters. We want to offer customized designs to make your job easier when you're fitting patients. That way you have all the parameters that you need to help the patient see their best and have a comfortable wearing experience. And then just also providing the resources of the diagnostic lens sets that you have, education on how to fit and use them, and then also the resources of consultation and feedback that are there for you throughout the process. And then this is the product portfolio for those of you who aren't too familiar yet with Bausch Lomb specialty vision products. Today we're obviously going to be talking about Zenlens. That's the scleral lens design that we offer, as well as there are other designs like the Novacone soft lens for irregular astigmatism, and then the C-View line of products, which offers various multifocals and toric multifocals, and then the Astera, which is a totally customizable design. We also have on there the option to use lens care products like Scleral Fill. That's a buffered saline solution, but I was told that it's not available yet in the Australian market. So for those of you who are getting started in fitting sclerals, the Adipacks, the non-preserved inhalation 0.9% saline vials, I've been using those for years. The non-buffered, they have done great for my patients. So if you're having success with those, I think you're okay to still continue using them. But I just wanted to have our product portfolio there for your reference. And then jumping right into the indications, that's one of the first things we like to talk about with sclerals, is they really do have quite a lot of use. The thing that everybody thinks of with specialty lenses like sclerals is the irregular cornea population. And primarily that makes us think of keratoconus, but there's also the patients who have had transplants, or those who have trauma and scarring for whatever reason. And it's quite a large group of the population of patients who need these lenses and benefit from them. So those are some of the demographic information, pieces of data from the US. But it really is a growing marketplace. There's some data published each year in Contact Lens Spectrum, and it's shared at the Global Specialty Lens Symposium meeting about how the trend in sclerals is just ever increasing year after year. So today we're going to be looking at just a general introduction to scleral lenses, and then we're going to hopefully make you all more comfortable with the fitting and assessment of them. So all the steps that need to be taken in terms of the evaluation, particularly as it pertains to the scleral landing area. That's going to be an area in which we have to spend more of our attention and time making sure that that area fits optimally. We'll compare and contrast the Zenlens and the RC options, as well as going over the safety information for proper handling of these lenses. So, as we said, indications are a good place to start, and this is the thing that comes to mind for most people, the corneal ectasias. And so you probably end up seeing more keratoconus patients than any of those. We do have the pellucids over here on the right. You see that type of, that classic kissing dove topography pattern there. And pellucids in particular, because of that inferior steepening, it ends up with, if you look at an elevation map on topography, you end up with this area that's just very, very low and depressed, making the cornea very, very asymmetric in shape. And when you're trying to fit a corneal gas perm lens on that type of an eye, oftentimes you get a lot of excessive inferior edge lift there, or you can even get that in more inferior cases of keratoconus, or if they have a very large oval cone, and that can make it challenging to keep the lens on the eye in some cases. Your patients might complain about the lens popping out because of that excessive inferior lift. As they blink, their lid may come up here, catch underneath it, and pop it out. And that's one of the great advantages of scleral lenses, is because of their size and how they evenly land on the sclera. It evenly distributes that weight, and that will remedy that issue for a lot of your patients who are complaining about that instability. Additionally, we have our patients who have undergone surgeries, post-surgical irregular corneas. Hopefully you don't see too many patients with RK. I see them every once in a while, but those of you who have know how tricky those eyes can be to fit with gas perm lenses, corneal lenses, because of how that shape may change throughout the day, as we've observed clinically. LASIK patients, not just because of post-LASIK irregularity, but also in one of our next upcoming slides, talking about the ocular surface and dry eye. Patients who do end up with post-LASIK ectasia, they have that more oblate shape to their corneas, and Zen has a design that works really well to fit that eye shape. But also those post-LASIK patients who end up with really, really dry eyes, many of them benefit from the comfortable wearing experience of scleral lenses. And then also post-PK, penetrating keratoplasty patients. But that's, again, something that's a little bit more debated amongst fitting experts as to whether those types of patients should be wearing scleral lenses to begin with. So that's something that you're going to want to manage with the corneal specialist, making sure that the endothelium's healthy to support lens wear. So those patients should regularly, every 6 to 12 months, be getting specular microscopy to make sure that the endothelium and the entire cornea, for that matter, is healthy enough to wear a lens. Transitioning right here into the ocular surface cases, like we mentioned, scleral lenses have been a great savior for managing patients with ocular surface and severe dry eye conditions. And so particularly those who have exposure. So I've had patients who have undergone surgery for cranial 7 issues, or have had traumatic episodes in which they've lost portion or all of their lid and they have a lot of exposure there. and scleral lenses just provide a comfortable, protective wearing experience for them, and it's really life-changing for a lot of them, and it's just so amazing to be part of the management process when dealing with conditions like this, and also Stevens-Johnson syndrome if they have any sort of limbal stem cell deficiency, Sjogren's being an increasing use of scleral lenses. Not sure if you have the ability to do testing for Sjogren's, but that's a practice building tip we give a lot of doctors in the US who want to fit more scleral lenses is some of these conditions, if you reach out to other doctors in your area and let them know what you're offering, let them know about scleral lenses and what you can do with them. You can reach out to oncologists for patients who have been getting radiation treatment, those who have had graft versus host disease, and reaching out as well to rheumatologists for those patients who have Sjogren's. And it can be a really big practice builder. So it's something that if you haven't thought about, maybe it's something to consider looking into as a way to serve more of these patients. So lots of different indications for scleral lens fitting. And like we had said, one of the great advantages is they're so comfortable. Because the lens doesn't land on the cornea like our GP lenses here, like this lens, very inferiorly decentered, obviously, but the lens is just riding as the patient blinks there and they feel it. The scleral lens offers a totally comfortable wearing experience for those of you who have not had one on eye. It does not move, so you won't feel those edges and you won't feel that lens movement. And then also, like the name implies, it lands on the sclera and the conjunctiva. So it doesn't share any of its weight on the cornea itself, also contributing to the comfortable wearing experience that your patients are going to enjoy. So that because it's not moving, it really stabilizes the optics for us. And that's great when we're dealing with these irregular corneas, particularly those who are, like in this case, a very, very inferior cone. You can see that the optic zone is pretty much bisecting the pupil now in that case. The advantage with the scleral lens is when it vaults over the apex of the cone and lands on the conjunctiva and sclera, you're going to have the optic zone centered then around the visual axis there. Whenever I do one of these presentations and I'm interacting with my audience, I like to ask, why some people aren't fitting sclerals yet, and what some of the hangups are with them. And some fitters out there are just that don't have confidence with them yet. There's some misconceptions and some myths about sclerals. These are some of the top 3 that I get most frequently. So hopefully throughout the presentation, we can dispel some of these myths and make you all more comfortable that you want to try fitting these lenses more and more. But one of the first things people notice about them is the size of the lenses. And it's for that point, it's really just about your confidence as the fitter. So one of the things I'd encourage you to do to get over this hump is to just practice putting lenses on either staff members or colleagues at the office, or even just family members. Say, hey, I want to just try this thing out that I'm interested in doing at work. And the experience really comes from you in terms of as you put these lenses on more eyes and you get more comfortable handling them, you will portray that confidence and comfort in handling them, and your patients are going to pick up on that, and they're going to have confidence that they're going to be able to do it as well. One of the other misconceptions is the expense of the lenses. I always explain to patients that these lenses are going to last them, and I do emphasize how customized they are for the patient. It helps them understand what the whole fitting procedure is and what we're really trying to achieve, the benefit of it all. And so that really builds the value of the experience for them. And then the third one, that scleral lenses are complicated or hard to fit. Hopefully, you know, we can very much dispel the myth by the end of this presentation. Again, like we were saying, scleral lenses rest on the conjunctiva and sclera, not touching the cornea. And these lenses are filled with that preservative-free saline. That's the key ingredient in the comfort and the relief for our ocular surface patients. And really what makes all of this possible is the high decay material. Scleral lenses have actually been around for a long time. They've really just recently become more popularized because of the new hyper decay materials that we now have. Previously, patients would wear these lenses and have to remove them multiple times throughout the day. And now with this high decay material, it's not really the case. So that's really where we've made the most progress. The Zenlens is, like we said, scleral lenses have indications for a variety of different uses. Zenlens falling along with that for all different types of corneal shape. For the very, very deep prolate eyes like we see in this image here, the moderate and advanced cones, and then patients who have shallower eyes. This is actually a great image because this is how I get started with my fitting. As odd as it sounds, in a lot of cases I look at how deep the eye is. So you can see that this eye is shallower. There's less space between the apex of this cornea and where the sclera begins compared to this eye. The apex of the cone is deeper and farther away before the sclera and conjunctiva in that left image there. So there's different shapes available, different diameters available, another great feature, and then it comes in various sagittal depths throughout the set. But just like any contact lens fit, it starts with hand washing and having the necessary tools available to us. So I like to use an insertion application DMV to put the lens on. I have fat stubby fingers, so it's not easy for me to get all to do like a tripod method that some fitters like to use. But you can use that. You can use your 3 fingers, your pointer, thumb, and middle finger together to stabilize the lens and put it on the patient. This is the removal DMV that you're going to want to have on hand for when you have to take the lens off. And then saline to put in the bowl. When you fill the lens up, you want to balance it here and make sure that that saline is filling all the way over the lens. It's pretty much overflowing with that meniscus there. And then you would apply your fluorescein for your evaluation into the bowl here. You want to really emphasize that your patient's head needs to be parallel with the floor. So I'll tell them to lean forward and tuck their chin down to their chest. Sometimes I'll put a drape or a paper towel along their lap and close so that we don't get fluorescein all over them. But you are going to apply the lens then right onto the center of the cornea. I like to have the patient pull down their lower lid to help me out with the process. So if I'm applying the lens to their left eye, to their left eye, I'm right-handed, so I always stand on the right side of my patient. So I have them lean forward, tuck their chin down to their chest, and if I'm putting it on their left eye, I'll have them use their left hand to pull their lower lid down. I'll manage their upper lid with my left hand, and then I also have them hold their thumb in the center of their lap, and that's a fixation target for them. I have them keep both of their eyes open. I continually remind them, both eyes open, looking at their thumb, and then I'll apply the lens right onto the center of the cornea, and it usually goes right in with that method. The fixation target really does help. If some patients aren't really helping you with the fixation target, with that lap towel or drape in their lap, you can just mark an X or some sort of fixation target on there, and that really helps in getting the lens on and avoiding application bubbles. So after you put the lens on, the very next thing you want to do is check to make sure that you don't have any air bubbles underneath the lens. If you do, you have to remove the lens fill it up all the way with saline again, and then reapply it. So you can't really ease these bubbles out in any way. You are going to have to remove the lens and then reapply it before going forward with your evaluation then. Just as a reminder, whenever you remove these lenses, you want to apply that small DMV to the outer edge. So I educate the patient at the outer edge of the iris. That's where they want to aim their small DMV plunger to remove the lens. After we have our lens on and we don't have any air bubbles, we do our slit lamp evaluation, and I call this the inside out approach. So the very inside center is the central cornea. We're going to evaluate our clearance there with our optic section. I like to use white light with my optic section evaluation. We have some images coming up. And then I'll scan edge to edge, all the way from one limbus to the other. So that's the middle portion of the evaluation, and then the very farthest edge of the lens, we're going to be paying particular attention to the conjunctiva and where we're landing on the sclera. Again, that's where we typically have to make the most changes, so we want to make a careful evaluation out there, make sure everything looks as it should. And when we put that lens on, I do think the cobalt light is very useful for getting an overall appreciation of how the lens is fitting here. So we have two different things going on in these pictures. The right image here, that lens is just too shallow. You can see how there's a central bearing type pattern right here centrally. So with your cobalt illumination, but you also see the Ratten filter being used here, it helps a lot with it. And this is a lower magnification view, like 6 or 10x. You can see any areas of touch that you may be getting over the apex of the cone. And then particularly, it's very valuable over the limbal areas. Scleral lenses do have a tendency to decenter inferior temporal. So if this is a left eye here and our lens is decentering down and out, then superior nasal area, we may be getting some touch here. So that's the first thing to assess in the limbal area with this cobalt diffuse illumination. I do oftentimes double check this though with a slit lamp and white light. Sometimes there's just very low clearance there and you can't really appreciate it until you look with your optic section and a more magnified view with white light. So I do recommend you double check that. But this is what we really want to make sure that you all have mastered by the end of this presentation, is this image right here. The white light optic section evaluation. I'd recommend doing this at 10 or 16x magnification. If you're really not sure about something, you can mag up to 25, but 16x usually does it. And you're gonna look to see these few cues right here. This shiny, shimmery front surface, that's the beginning of the lens. The dark space here is the lens thickness. For the regular Zenlens set, the center thickness is 350 microns, which you are then going to compare to the green band behind it. So this is our schematic of what we just showed. This is again, it's a little tricky to see with the white background, but the reflecting front surface there, the dark space for the lens thickness. And some new fitters are tempted to compare it to the corneal thickness just because it's easier to appreciate, but you shouldn't get in the habit of doing that because, as we know clinically, people's central corneal thickness can vary patient to patient. And then if we're working with ectasias, we know that causes corneal thinning. So the corneal thickness can be fairly unreliable when we're trying to compare our sagittal depth to something concrete. So in this case here, you can see that green tear space is less than a 1-to-1 ratio compared to the 350 microns of the center thickness of the lens. And I shoot for a 1-to-1 or a just under 1-to-1 ratio. I like to have somewhere between 250 and 300 microns of initial clearance with the expectation it's going to settle somewhere between 100 and 150 microns after the lens has been on the eye for a couple hours. But this is what we're really trying to evaluate. So for our clinical image here, you can see that in this instance, we have a greater than 1-to-1 ratio. So we're a little bit greater than that 350 microns of central clearance there. We may need to drop our overall clearance by a bit. So just comparing those two images side by side there. Again, a less than 1-to-1 ratio and then a greater than 1-to-1 ratio where that tear lens is greater than the thickness of greater than the center thickness of the lens itself. After you've had some practice with this, the next skill would be to be able to evaluate the eye with and the lens without any fluorescein behind it. And so this is what it looks like during a follow-up here. You can see the shimmering front surface of the lens here. And it's a little challenging to see the back surface of this lens. So if you're really not quite sure, you want to make sure that you use as bright white light optic section as you can. And if you still can't appreciate the back surface of the lens under higher magnification, then in some instances, I'll put the patient behind the OCT. I do like to use anterior segment OCT images. This one is a 5-line raster image of the lens on my patient's eye. And here, this is post-settling. So 230 microns post-settling may be a bit too much, but this is an instance in which I'd let the patient go with it and just follow up with them. I like to follow up after I dispense a lens. I always like to follow up with my patient about 2 weeks later, and I will ask them to wear the lens on the eye for at least 2, preferably 3 or more hours to be able to evaluate what the lens looks like after settling. And so I do use OCT images, but this is what you're judging in that case, the space between the back surface of the lens and the beginning of the epithelium. Because you want to make sure that this is not happening at that follow-up. You want to make sure that the lens is still clearing the cornea. In this case, the lens has settled more than we expected, and it is now touching centrally across the apex of the cornea here. It's a little bit hard to appreciate when you don't have fluorescein in the bowl, but if you look carefully, you'll start to pick up on some of these cues. So you can see the back surface of the lens, that shimmering white surface there, and then it intersects with the cornea epithelium here, and now basically the center thickness of the lens is right here, and it's right up against the epithelium of that patient's eye there. So this would be an instance, and you should be doing this anyway during your follow-up evaluations. After you evaluate how the lens looks with your optic section, you've assessed their acuity, checked for any rotation and how the lens is fitting out in the peripheral curves and along the sclera. After you evaluate all of that, you should remove the lenses and evaluate the epithelium and the rest of the cornea underneath. Apply some fluorescein there, check for any areas of staining, because in this case you're probably going to see some staining. That lens needs to, you're going to have to add sagittal depth to this lens to make it a bit deeper to get the lens up off the cornea. So the scleral landing area is the, like I said, that's going to be the area that we have to pay attention to the most in our evaluation and our troubleshooting, looking for areas of compression, impingement, and what we typically see, edge lift. So compression is that blanching appearance that you see on the conjunctival tissue. So you'll see an area of whitening where the lens is pressing down harder. That can happen anywhere along the landing area, along the landing zone. Your patient may mention or complain about injection redness, hyperemia with the lens removal. They'll say at the end of the day when they take their lens off, their eye will get really red. And so if you hear them mention something like that, this is what you want to look for. Again, that's why you should have that 2-week follow-up with them to return to your office having worn the lenses for several hours so that you can check for this sort of thing, because you may not always notice this initially upon your dispense. They'll also complain about the lens feeling worse or symptoms worsening the longer that they have the lens in. And so this is what you'll see there, that white blanching with the injected, engorged blood vessels leading up to it. Impingement's a little different because this is something that always occurs at the edge, and you can kind of think about it synonymously with pinching. So you can see here this compression image is whitening, and it's somewhere in the middle area of our scleral landing zone. But impingement is going to occur, like we said, at the edge, and when you remove the lens, you may notice conjunctival staining. In long term, if this is not dealt with, you can end up with laceration of the tissue out there and conjunctival hypertrophy. So when you have the lens on there and you apply fluorescein, you can kind of see how this edge is in focus in the slit lamp image, and this edge is partly in focus. That area is just out of focus because of our magnification. But the area between the two there, you see that it's kind of blurred out, and you can maybe appreciate better on high magnification. But when you go ahead and remove the lens and apply your fluorescein, this is what you're going to see. This is that pinching or laceration on the conjunctival tissue here. So again, that's why it's important to remove the lenses at that 2-week follow-up to make sure that you're not getting this, that you're not inducing this impingement anywhere. And then long term, like we said, that can result in that hypertrophy in that area, and then you'll just end up with more and more scarring and irritation out in that area if you don't troubleshoot and resolve that. The other thing that you can run into with these two is if you're dealing with fitting around a pinguecula. The microvault that Zenlens offers, one of the features available, is a great way of dealing with this issue. We'll have the slide on that towards the end of the presentation to just go over that then. But these can be kind of tricky, so I do want to go over the microvault then. But as I said, edge lift is probably the thing that I encounter most in fitting sclerals. This results from the lens not properly sealing off all the way to have an area of edge lift and interaction with the eyelid. So if your patient complains about lens awareness or feeling the edge, this is probably what's going on. You may notice the lens moving as well. This is just because it's not contacting with the rest of the conjunctiva and sclera. So here, this is a very exaggerated image of it. Here we actually have an air meniscus. So the patient is really going to be unhappy if this is how the edge of the lens feels. But this would be something where you'd have to steepen the peripheral curves, the APS as it's referred to in Zenlens. You would steepen the APS to get rid of this problem. Many times it's much more subtle than that previous picture, in which case you can't always tell with just white light and your slit lamp examination. You can sometimes get a false sense of edge lift because of the thickness of the edge of the lens itself. So depending on how your light is displayed, you can sometimes think you have edge lift when you don't. So I really like fluorescein to help evaluate for this issue. So after they've had the lens, this would be something after they've had the lens on for a little bit of time. So if you're doing your fit, I would wait to do this till after your over refraction and pretty much just to right before you're ready to take the lens off and finish up. But apply some fluorescein there and you can start to see it trickle in from the edge there. And that's how you're going to pick up on edge lift that the patient may be struggling with. And again here, that edge lift, as you apply the fluorescein to the front surface of the lens, in this case, we're getting it here inferiorly coming in. And this is typically the case. This is what we refer to as with the rule scleral toricity. And what that means is, as we've studied the eye's shape, the anterior segment, both the cornea and the shape of the sclera, we know that there's variation in the curvature and then the elevation along the horizontal and vertical meridians. So we know that the vertical meridian is typically higher elevation, flatter in terms of its curvature. So the lens lands at 3 and 9, and then you have more edge lift in some cases along the vertical meridian. And that's what we're seeing here, that edge lift along the vertical meridian where the fluorescein is getting in from because of that edge lift. And we do have an answer for that tear exchange, which we'll get into in just a little bit. But after our introduction and our evaluation and troubleshooting here, I wanted to take a short break and go over what questions we may have so far.
Okay, thanks, Nick. I've got a couple of questions here. Number one is, what are the contraindications for using Zenlens?
That's a great question. So as far as contraindications, there are two that come to mind the most, and this is something that's debated amongst fitters. So I had mentioned post-PK patients, those who have gone through penetrating keratoplasty, and it's still being debated as to whether these patients should be fit in sclerals or not. I have several patients, quite a number actually, because post-PK patients can have very, very irregular eye shape and have lots of variance in elevation across the shape of it, which makes it very challenging in some instances to fit corneal lenses. However, it's, again, something that you're going to want to co-manage with the corneal specialist who is aware of the status of their graft and knows about their endothelial cell counts. If you have that information and their eye is healthy enough to wear a lens, then by all means, you can definitely fit those patients, but it is something that you have to be a bit more cautious over. Also, making sure that when you fit that eye, that you're not touching the graft-host junction. That kind of goes without saying, but that's just something to remind you of, and that's one of the great advantages of the oblate shape that we're going to get into in just a moment when we talk about the set. But the oblate shape is excellent for making sure that you have enough clearance in that mid-peripheral corneal zone to not bear any weight on that graft-host junction. And then the second condition are patients who have a history of herpetic eye infection. Obviously, we don't want to fit a contact lens or have a patient who has an active herpetic infection to ever wear any type of contact lenses, but I am careful with these patients as well because, again, we want to make sure that because scleral lenses don't move on the eye, and we don't want any tear exchange underneath them, all of the oxygen permeability to the cornea comes from the hyper decay material, and then the greatest barrier to the oxygen is actually the tear lens between the lens and the eye, so that the actual artificial tear, the actual saline solution that you fill the lens with, that actually has lower decay than the decay of the GP plastic, which I was really surprised to learn. But you really have to optimize your fitting, the clearances for those patients. You can't overvault them because then you're delivering less oxygen to the eye. And I just am very cautious to not aggravate a post-herpetic infection for patients who have that history.
I've got a couple more here. Would you put a toric APS first when fitting a 17mm lens, or would you check toricity last?
Well, I actually, because I've been fitting so many sclerals over the last few years, I actually have an all toric set that I personally use. So I use toric peripheral curves for all of my 16 and 17 millimeters, or almost all of my 16 and 17 millimeter fits. But the For 17s, I think what that question is alluded to is that we know, based on our eye-shaped studies, that as we move farther and farther away from the cornea, the variation of the curvature and the elevation difference across the horizontal and the vertical meridian increases. And so yes, the farther away you land the lens from the cornea, the more likely you're going to need toricity in the APS, which we're going to get to in just a moment. So I do recommend fitters do use the toric lens to just make sure that they don't have any edge lift when they're going through their fitting. So that's a very good point to bring up, just to be aware that as you when you fit a larger lens, you're more likely to need to incorporate toricity to account for that difference in the horizontal and vertical meridians.
What happens if I fit a spherical APS and have ordered a front surface toric, but then find it aligns to a back toric surface and is now the front toric is now off center?
Okay, so yeah, I do recommend in that instance that you do, when I do use front torics, I will almost always use a toric back surface to help stabilize the optics. We have a video of that coming up. And it also, in some instances, helps with our centration as well, as that question alludes to. If you're fitting a front toric and the lens decenters, that can affect the quality of the optics the patient's experiencing, but also any rotation that can, obviously throw off the quality of the vision as well. So I would encourage, if you're doing a front toric, to use a toric APS as well to stabilize the optics.
Is it best to assess clearance over center or the apex for a keratoconic?
Great question, and I look at both. So yeah, I like to train fitters to have the first thing that they do after application and checking for bubbles. The very next thing for them to do is to evaluate the central clearance over the visual axis. But yes, that question is a great one, because we always want to be aware of, when we're fitting over keratoconus, we always want to make sure that we're not touching on the apex of the cone. These lenses aren't intended to have that 3-point touch, or any sort of bearing pattern for that matter, like some GP lenses may be fit. We want to totally, completely vault the cornea. And so yes, when you're fitting keratoconus patients, make sure that you evaluate over the apex of the cone. So I'll shoot for about 200 microns of apical clearance over the cone in those patients, with the expectation it'll settle somewhere between 100 and 150 microns. So then we will still be clearing that area.
Okay, the final question for this session. When the lens does settle, so there is contact with the cornea, how much would you increase the sag by? Is there a minimum step for this?
Yeah, that's another great question. So that you have to go off of how much area of touch you're getting. So that's where that diffuse cobalt image would be helpful. If you see a large area of bearing, you know that you're pressing a little bit more, and you're going to have to increase your clearance more substantially. The Zenlens set, each lens step in the set goes in 300 micron units. So if you're very, very close and you're just barely touching it, then going up one lens in the set, adding another 300 microns is probably going to do it, or just about do it. However, if you have a large area of bearing like that one picture showed, you may have to go up almost 2 steps. So you may need another 500 microns or something. So it is more difficult to be touching the cornea and then have to go up in your sagittal depth to get off the cornea. It's less certain, versus if you're overvaulting the cornea, you can better appreciate how many microns you have to adjust your clearance by to drop it down.
That's about the only questions for this session so far. Thanks, Dr. Nick. We'll
All right.
pick up a few more afterwards. Thank you.
Excellent. Okay. So we mentioned the variety of lenses that you have in your set, and this is one of my favorite things about Zenlens is that everything you need is in one box. So you have two different diameters, a 16 and 17 millimeter diameter lens, diagnostic lenses, and then you have two shapes. You have prolate shapes, which you're going to use most of the time, but you also have oblate, and those are really, really handy for when we're fitting, like we said, those oblate eyes that are post-penetrating keratoplasty, clearing the graft-host junction, or post-LASIK patients, making sure that you're not, that the lens isn't bearing down over the flap. There's the advantage of the smart curve technology, which we have a slide to explain that in terms of making adjustments throughout the different zones of the lens. Mentioning the zones, the landing zone that Zenlens has is a pretty lengthy one, and that's a good thing. That's what you want to look for in a scleral lens. I kind of liken it to if someone steps on your foot with a regular shoe, it's not going to feel as bad as if somebody steps on your foot with the heel of like a stiletto. So a wider landing area, that extended landing zone, is going to distribute its weight more evenly and more comfortably versus a narrower landing zone, which is going to come down like that stiletto heel. And then the microvault to get around those pingueculas, like we alluded to earlier. So I begin the fit with the diameter evaluation. It's one of the most important things in fitting any type of contact lenses. Scleral lenses are no different. The average HVID is about an 11.7 millimeter diameter, so that or less. You're going to want to use the 16 millimeter diameter diagnostic lens. Anything larger than that, then you are going to want to start with the 17 millimeter. This is one of the best features here, is these built-in drill dots to evaluate your diameter, and this is exactly what you want to see here. So you want the distance between the edge of the limbus and this drill dot to be about just about 1 millimeter or just over 1 millimeter, and that tells you that you have the appropriate diameter then. Few things can derail a contact lens fit, and particularly a scleral lens fit, like selecting the wrong diameter. If you have a lens that's too small, you're going to be continually struggling to adjust your limbal clearance, and you're going to be adjusting and adjusting and adjusting and changing and changing and increasing the microns, and you're not going to be getting anywhere with it. And it's really something that would be so easily remedied if you had just selected the right diameter initially. And that's one of the best qualities about the Zenlens design here. You can see is how easy and clear those diagnostic markers are to make sure that you have the right diameter selected initially. And then the option, like we said, the two different shapes, prolate and oblate, and it's organized into the set as such. So you have the whole prolate section here in the top, the whole oblate section on the bottom, and then it's organized based on the diameter from there, with 6 different sagittal depths for each diameter and shape. And then finally, at the end of each row, there's a toric peripheral curve, toric APS lens to use in your evaluation there. So I do encourage that you put these lenses on and do use them, particularly if you're ordering a front toric, just to know how the lens is rotated and just to be able to stabilize the optics for yourself. But like we said, as we fit larger lenses, the 17s land farther away from the cornea, or if we fit on more toric and irregular sclera, it's very valuable to have that the toric APS for those patients and for troubleshooting tear exchange, like we're going to get to. But just as a reminder, this is what we're meaning when we're talking about prolate versus oblate. So the prolate shape, steeper in the center and then flattening towards the edge, versus the oblate, where it's a little bit flatter base curve here, centrally, and then there's an area of a bit more reverse geometry out here where it's a bit steeper to give us more peripheral clearance out at the farther edges of the cornea. So again, very handy for when you're fitting those oblate post-PK patients, clearing the graft-host junction, which is an absolute must in a scleral lens fit. Great for Salzmann's nodules out in this area, clearing those little bumps out there on the cornea and the farther peripheral areas, and then clearing like the flap in a post-LASIK patient, but also post-refractive surgery patients are often more oblate, so these lenses just fit the eye shape better in those instances. Mentioning, we had spoken about depth before. This is what I mean, and I like to evaluate I'll stand actually next to my patient and look at the depth of their eye externally outside the slit lamp and see the space between the apex of their cornea and where their sclera begins. And it sounds kind of like a funny notion, but if you do this more and more, you're going to gain an appreciation from how deep an eye is compared to how shallow they may be. So if you look at more of these eye profiles from the side, you'll start to find yourself saying, oh, that person has a deep eye or that person has a shallow eye. So the more of these you look at, the more this makes sense. And this is how I typically begin my fitting. Most cases we're dealing with prolate eyes, and if it's an earlier or milder keratoconus patient, or if they're a normal type of cornea, or if it's a pellucid like this, I oftentimes start with Z2. That's kind of my go-to lens, the 16mm prolate, and that's usually where I begin my fitting, 4,500 microns of sagittal depth there. And put the lens on. This is what I meant before when I was talking about the area of bearing. So if the lens is too shallow and you see that you have a large area that the lens is pressing down in the cornea, that tells you you're going to have to increase your clearance by a greater amount. So again, like we said, using the optic section white light evaluation, this is what we're looking for. Just as a review, the shimmering front surface there tells us that then the space behind it, that dark space, is the center thickness of the lens. So again here, that's 350 microns. So we have a greater than 1-to-1 ratio. So if this is our Z2 lens and we put this on a normal cornea patient and we see this, that tells us that our sagittal depth is too deep and we're going to have to drop it down by a little bit. So I don't know if we actually have 300 microns to spare. So if we drop this from Z2 down to Z1, it may be too shallow in that case. So this would be something that I may not drop by a whole lens, a whole diagnostic lens, but really just describe it to consultation and have a more customized adjustment to the central clearance. So what you could tell them is just, you know, I put the Z2 on and I have, if you want to call this 400, 500 microns of central clearance here. So I want to drop it by 150, and they can do that for you. So if you're making small changes to the clearance, you can just describe that, versus if you're going to make larger differences in clearance, if you're going to make like 250, 300 micron changes, then you're going to want to put a different lens on from your diagnostic set. But this is one of the great advantages of the smart curve, is the smart curve allows you to make adjustments throughout the different zones of the lens without it throwing off all of the other ones. And this is what we mean here. So when you're evaluating, like say in this instance, you're evaluating the limbal clearance and you're noticing that touch there, superior nasally, you can then describe, you know, we're getting touch there in the limbal clearance, so we want to increase our limbal clearance, but I'm really happy centrally. I don't want to have it impact the central clearance. So when you change a limbal curve in a lot of other scleral designs out there, it throws off your central clearance and a lot of the other curves through the lens. The smart curve, if you increase and steepen that limbal curve, the smart curve just automatically is adjusted in the software to maintain your overall sagittal depth. It's a great feature that the Zenlens has, and it's really, really helpful from having to get all of your curves thrown off and then having to change multiple things whenever you're trying to adjust the fit. So it makes it very, very easy, simple and straightforward for the fitter. Next thing, like we mentioned, is the APS, the scleral landing area. Like we mentioned, it has that wide scleral landing area. It has that equal distribution of the weight. And then the toric peripheral curves are very valuable, particularly when you're doing front torics to stabilize those optics, or if you're having tear exchange or areas of edge lift, the toric APS is going to be a solution in a lot of those cases. Comes in one-step increments, each step being a 30-micron adjustment. So the default for the Zenlens set is a flat 3, steep 3. Flat 3, that's going to be 90 microns of flatness along one meridian and 90 microns of steepness along that steep 3 meridian. So you can adjust in one-step units there as you need to. Because if you apply a spherical lens to a toric cornea, this is what you may end up seeing here. So the lens is on there as they're blinking. You can see it's moving around. And pretty much instantly when that fluorescein is applied, you can see it's starting to leak underneath the edge of the vertical meridian there. And that's not what we want to see. The lenses should settle into the conjunctiva and seal off all the way around to ensure that we're not getting unwanted tear debris accumulating behind the lens. That's what contributes to that midday fogging issue that we end up having to troubleshoot with our scleral lens patients. And here is the rotation of the lens on the eye. So if you're doing a front toric there, during your fit, you would have evaluated the flat meridian markers. When you're doing a toric APS lens, the flat meridian is usually located along 3 and 9 o'clock, but in this case, it was probably rotated 30 to 45 degrees here to the right. So you would have explained that to your fitting consultant and said, you know, we're rotating to the right here. We need to make an adjustment. So it's just like we call it LARS in the American Optometry schools, left add, right subtract. So if you're rotating to the right here by 40 degrees, you're going to have to subtract that off of your over refraction. But the video here was great in showing that the toric APS stabilizes the optics so that it always returns to that position, versus if it's non-stabilized, as they blink, you'll see that marker swing wildly back and forth. It's not going to return to the same position, and the patient will complain of fluctuating vision. So now we've changed that previous fitting lens to a toric APS here, and as we apply that fluorescein there, you can see that we're not getting that fluorescein exchanging and coming in. It's not, I call it bleeding in behind the edge of the lens now. Now we're more uniformly aligned to prevent that tear exchange and that fluorescein from getting in behind the lens. You can evaluate that as well with having the patient look in different positions of gaze. In this case here, we describe it as against the rule toricity, where the lens is actually too tightly fitting along the vertical meridian here. You see that blanching there. So that's actually going to have to be flattened along the vertical meridian, which is usually the steeper meridian of the two. So the toric APS is going to help in those instances. These are the parameters that the lens is offered in with the features of it available in XO and XO2. I pretty much use XO for my Zenlens patients, so great material that you can use to give you know, optimal oxygen permeability. This is what we mentioned before about pingueculas, is the microvault. So the microvault is kind of like a little speed bump in the lens here. I like to kind of describe it. It's just designed to get up and over around the pinguecula. So in this case, totally spherical peripheral curve here, and we're having that compression, that whitening, that blanching over the edge of the pinguecula here. But with that little bump in it, that little microvault, we're getting up and over that to make sure that it's not compressing down there. And to incorporate this, all you have to do is just measure things. So you have to measure rotation of the lens. In this case here, your lens may be rotated about 10 degrees to the right or something if the flat meridian marking is located right here. You can measure the width of the pinguecula with your white light on your slit lamp. And then you would describe what the depth of it is. And you can actually measure that with your OCT like I did here. That's the high definition raster line image that I took off of my OCT there. And you can see in that instance the depth of that. So that's a pretty mild pinguecula, but you can relay that to your lab and they can get that designed into the microvault then. And then last, I just have a case here to just kind of put all this together. So if we had a patient who had an HVID of 11.7, again, that's a pretty average sized eye. Say this is a fit for dry eye, so they're a normal cornea patient, so it's a prolate shape. That leads us to that initial Z2 lens, like I mentioned, it has 4,500 microns of sagittal depth. We put the lens on and there's no bubble upon the insertion, so we're in good shape there. We'll look behind the slit lamp next. And then that shows that we're just under a 2-to-1 ratio. So if the lens is 350 microns thick, a 2-to-1 ratio, we're looking at 700 microns there of clearance. So definitely way too much. So if we drop then from a Z2 down to a Z1, remember there's 300 microns of difference in clearance between lenses. That's going to bring us closer to a 1-to-1 ratio. We got about 400 microns of central clearance now, which still may be a little bit too much. I'd probably drop it another 100 microns, but you could probably just order that and see how it works out for you at the follow-up. But then, of course, you would check limbus to limbus, making sure that it covers the cornea and isn't touching anywhere, and then evaluating your APS, making sure that there's no blanching or edge lift. After you're happy with your fit, you do your over refraction, vertex if you have to, and then you're ready to order. So you just say, I'm going to order a Z1 lens. You could say, I just want to drop the clearance by 100 microns. And then you just, if you have any limbal or APS adjustments there, you would explain that. And then along with your over refraction, the Zenlens set has a -2 diagnostic power across the set. So that's really nice that you don't have to go double checking, what each diagnostic power is. So it's nice to just know that, this is the diagnostic power across the set. So you're in good shape then. So just summarize to the takeaway points from the presentation. You have 5 fitting sets in one, basically, with the Zenlens set, considering that you have 2 different diameters, 2 different shapes, and then you have toric lenses as well as the spherical APS lenses. The wide landing zone helps to fit the lens and align it to the sclera, such that you don't have to deal with compression, impingement, or edge lift nearly as much as you may in other designs. Smart Curve makes it very simple to make adjustments at one curve without throwing off all the rest of yours. Makes the changing and customization of the lenses really quite simple. Great fitting consultants at your disposal. So if you have questions or issues that you run into, you can just describe what you're trying to work around, and they're going to take care of the rest for you. And then a great warranty program, 120 days, to make sure that you get the best fitting lens that you can. And with that, we can take any final questions.
Okay, we've got a couple of final questions here. When would you use a 16 or 17 millimeter Zen lens for dry eye rather than an RC?
Great question. Throughout the presentation, I really am focusing on the regular Zenlens set. And I didn't always have an RC set in practice, and so I would really just rely on I would start for most of my normal cornea dry eye fits, I'd start with the Z2 lens, 16 millimeter prolate, unless they had a larger cornea, of course. And I found that I had to do a bit more changing in like the peripheral curves for those types of instances. The great thing about the RC is that it's tailor-made for those normal cornea patients. The RC stands for regular cornea. That's what the name implies. So with the RC, you can still fit a regular Zen lens on a normal cornea patient. You just may have to adjust your limbal and APS curves a little bit more, do some more tweaking there, as compared to if you put an RC lens on. There's the peripheral curves are designed such that it's going to fit better initially, so there's less troubleshooting that you have to do later. But you can fit that type of a patient in either lens. I love the RC design. It makes it so much faster and easier for when I'm fitting a normal cornea patient to just put one of those lenses on. They go in 100 micron steps, so if you want to see a smaller change and you feel like you're very, very close, you can just make a smaller adjustment. Fitting those types of patients, you really have to optimize your clearance. So you have to really nail your central clearance as compared to a keratoconus patient who has irregular astigmatism. Just the GP optics alone and the tear lens correcting the irregular astigmatism, they're much easier to please from a vision standpoint optically. So that's one of the nice things about the RC, is that you can go in those smaller 100 micron steps to really make sure you're optimizing your clearance then.
And that's the end of the questions tonight, Dr. Nick. Thank you very much for that. Is there anything else you'd like to add yourself? Anything I can leave you with?
Well, that was yeah. I mean, thank you for the questions. Those were some great ones from the audience, and I would just hope that some of you are just as excited as I am about sclerals now. Like I said, they're extremely rewarding in terms of practice. Our irregular cornea patients, you're their hero because you're providing them now a comfortable wearing experience. You're giving them the best vision that they've ever had. And also those dry eye patients and ocular surface disease, they're so thankful. Many of these patients have been struggling for a very long time. And when you're there to offer them this solution, they're just so appreciative. And it's just the most rewarding thing ever, being able to make this type of a difference in that person's life. So I hope some of you are inspired by this and are excited to get back to the office and start fitting sclerals, because it's, like I said, it's one of the most rewarding things in the profession.
Thank you, Dr. Gidosh, for sharing your time and experience with us all tonight. We do appreciate the fact for you it's very early morning and you've now got a long day ahead. So if anyone has any further questions or would like to know a bit more, please contact me at Gelflex Melbourne on aclorders@gelflex.com. And I'll do my best to help you out. And thank you all for your attendance tonight. And we look forward to taking care of your Zenlen needs in the future. Thanks again, and good night to you all.
Thank you.